Hi, my name's Dr. Allen. I'm a GP at Burley Health Centre. This is just a quick attempt to share with other people some of the ways that we've fleshed out some of the recent changes in approach we've had to make due to coronavirus. I'll discuss some of the changes to access to care, how we've communicated with staff and with the public, show you some of the things around the building that we've had to do, and just share some of the principles and strategies that we found helpful. The trickiest bit has been reframing how to access. So anyone with a new cough or fever is directed to 111 online. Sometimes they're redirected back to us and we will call them. Everyone else is put on a list for clinicians to share. Most issues are dealt with over the phone. We only invite people up if there is uncertainty about the diagnosis or the need for admission, where examining the patient would resolve that uncertainty and it feels an important enough issue to bring them in that put them at risk and us at risk to actually see them physically. Deciding on the need for examination is quite personal. We find 5 or 10 patients a day needed. We invite up out of 8,000 patients. We've installed an intercom and people are only let in if they've been screened and there's been a decision made that we think it's worth them coming. Anybody with a cough or a fever or living with anybody with those symptoms, regardless of their reason for coming, we treat them as a possible COVID patient. We inform reception a possible COVID patient is coming. When they arrive, they are redirected to the side door and the clinician is informed. We don our PPE, we take a mask for the patient and then we bring them in and lead them through. We've got government cleaning instructions next to the equipment. To avoid cleaning blinds, we've blacked out the window for privacy, which we open after the patient has left. We have PHE instructions on the wall for donning and doffing. We indicate on the door once the room has been used. If a patient has no COVID symptoms, they come in the main door by the intercom. The NHS stop board lives outside. Patient info is in the porch for reception to direct people towards. The waiting room is a handful of wipeable, spaced out chairs, and we've decluttered our rooms aiming to make them wipeable. Our appointment system is now transitioned to 4 phone lists, one for on the day clinical requests and one for on the day nursing requests. The other 2 are lists for GP follow-ups and for bloods. So for example, if a follow-up is needed in about 2 weeks' time, we put them on the list for 2 weeks' time. When that day comes, we can phone them and we can reassess to make a fresh decision on the necessity to safely, physically bring that person up. And we do the same for blood tests. Keeping up to date is essential. We found being networked through WhatsApp with other clinicians who are finding updates, posting them. The government website is excellent, as is Primary Care Pathways, a website that has collected lots of very useful resources altogether. We've been meeting daily as a team, and one of the exercises that we do to start is a check-in to see how we're doing. We go around and rate how well we're coping. If 0 is I'm going to go off sick tomorrow with stress, and 10 is I'm actually coping and thriving in this challenging environment, and it enables us to get a feel for how the team is, but also attend to people who need particular support. We share positive stories about our service or nationally that helps us to keep our spirits up and keep perspective. We use those times to communicate the latest advice, what our current strategy is, and updates on staffing isolation. To save reception having to go into too much detail with patients about the rules, we've created some preset text messages that communicate the up-to-date government guidance, and then we can text it to those patients in an instant. We've tried hard to reduce the footfall into the practice, so ways that we've done that is to be proactive in setting up electronic prescriptions for patients. If there's a pile of paper prescriptions, we ring those patients and we find a pharmacy that's convenient for them and we set them up. Sick notes, when they're requested, we take an email and we email it to them, and any that we have lying around, we proactively do that. If there's no other way, we post to prevent people coming up and to get paper. We've been keeping the prescriptions to 1 month only to prevent any shortage of medications. Some services have found Accurate's texting service to be very useful. Communicating to patients has been vital through this period, signposting people to 111 and ensuring that our patients are aware of the way that we're functioning with our new system to try and save receptionists from spending lots of time explaining these things. We've adapted the phone message, we've put posters in the entrance hall, and we've put information on our website. We learned from an incident where a patient withheld information about their symptoms to get seen, and we feel it's now really important to really make sure that people know that if they do need an assessment, they will be seen if needed. We have 2 GPs who are leading on COVID, and between us, one of us is present each day. Our role is to keep up to date, communicating with staff, forming strategy for us and for the primary care network. Staffing roles have changed significantly, and this GP ensures that team members remain effective despite all of these changes. We're the go-to person for any COVID incidents, so staff don't feel like they need to fix things themselves. However, we've found that these GPs need cover day to day from the usual clinical duties to enable them to be effective. Clinically, we need to help each other, to help us to make tougher decisions over the phone. We've gone through resources like telephone triage that have been passed around on WhatsApp to help us to upskill in working in new ways. We've enabled it so that patients can send photos, and we've used text presets with our email on to enable people to send in pictures with their name, their date of birth and which clinician it's for, and we found that to be very, very helpful. Chronic disease, we're largely aiming to manage remotely where possible. There's guidelines around the prioritisation of routine work that's available. There's a handful of principles that I've found important to try and communicate to our staff. Successfully transitioning to new ways of working will likely lead to some patient inconvenience, imperfect communication, and even some possible mistakes. We've communicated the need to be kind to ourselves and to one another, and accepting that we're doing the best in a challenging time. We're also aware that efforts to keep people away from the practice does involve some small clinical risk increase. However, as we're trying to reduce the risk of transmitting COVID, we've tried to ensure staff that we support them as they balance these risks, and also that GMC and our protection societies recognise that we need to be doing this. We're attempting to be very careful and organised around patients who are coming up to our practice, and I think that this makes us a relatively safe working environment for our staff. However, we also do need to acknowledge it's a risky time, and that our patients need us and that we need each other, and at times we do just need to be brave. However, we also reassure our staff that we'll help them when they're not feeling brave. And we think this is likely to be a marathon rather than a sprint, and whilst it's been frantic trying to make these changes, we're now expecting that we need to get into a bit of a rhythm. Now, a lot of this advice that we're functioning with at the moment will quickly come out of date, and we're trying to keep engaged with all the changes that are going on, but hopefully some of these principles and ideas may just be helpful. Thanks.